There's a diagnosis that clinicians whisper about in hospital corridors, one they hesitate to write in charts, one that makes therapists close their schedules and emergency rooms tighten their policies. For decades, it carried a single, devastating message: untreatable. And that was a lie. Not a small misunderstanding, not an honest mistake. A lie so pervasive, so deeply embedded in psychiatry, that it destroyed lives. People were turned away from the help they desperately needed. Families were told there was no hope. An entire population was abandoned by the very system designed to help them. Tonight, we're talking about borderline personality disorder. And I need you to forget everything you think you know. Because the truth, the real truth, is nothing like what you've been told. Take a slow breath. Picture a moment when you felt completely misunderstood, when the emotions inside you seemed too vast, too intense for anyone else to grasp. Now imagine that feeling, not as a passing moment, but as the backdrop to your entire existence. And imagine being told by the people who should help you that you can never change. But here's where everything shifts. Here's the part that changes the entire narrative. BPD is actually one of the most treatable mental health conditions we know of. Recovery isn't just possible, it's probable. The suffering was never inevitable. Much of it came not from the disorder itself, but from being told it was hopeless. So, how did an entire field get it so wrong? And what does that tell us about the nature of healing, the power of stigma, and the resilience of the human mind? Historical context. Between worlds. The year is 1938. Psychoanalyst Adolf Stern is studying patients who perplex him. They don't fit neatly into existing categories. They're not psychotic. They haven't lost touch with reality. But they're not simply neurotic either. Their struggles go deeper. They exist, Stern writes, on the borderline, between these two worlds. The name stuck, even though it never quite fit. Borderline suggests something mild, something at the edge. But ask anyone who's lived with this condition, and they'll tell you, there is nothing mild about it. The term became a kind of diagnostic limbo, a place where people were sent when clinicians didn't know what else to call their suffering. Through the 1950s and 60s, understanding evolved slowly. Otto Kernberg, working within the psychoanalytic tradition, began to describe a distinct pattern: intense and unstable relationships, a fragmented sense of self, primitive defense mechanisms like splitting, viewing people as all good or all bad. His work brought structure to what had been diagnostic confusion, but it also brought judgment. In his framework, people with borderline features were seen through a lens of deficiency, what they lacked rather than what they were enduring. Then in 1980, the DSM-3 formally recognized borderline personality disorder as a distinct diagnosis. For the first time, there were specific criteria, a framework. But there was also something else, the beginning of systematic research that would eventually overturn everything. The old narrative said, personality is fixed. If someone's personality is disordered, they can't change. Treatment is futile. But here's what research actually showed, slowly, painstakingly, over decades. People with BPD could recover. Not just improve, but truly recover. The disorder once considered untreatable became, in researcher Mary Zanarini's words, the most treatable major mental health condition. And here's the revelation: the suffering was never inevitable. Much of it came not from the condition itself, but from stigma, from clinicians who refused to treat, from emergency rooms that turned people away, from a system that labeled them difficult, manipulative, attention-seeking. The very people who needed compassion most were met with rejection, which only deepened their wounds. What if the suffering wasn't just the disorder, but the way the disorder was treated? What if recovery was always possible, but the path was blocked by prejudice? the clinical picture. What BPD actually is, according to the DSM-5, BPD is characterized by a pervasive pattern of instability in interpersonal relationships, self-image, and emotions, along with marked impulsivity. This pattern begins by early adulthood and appears across many contexts. To receive the diagnosis, someone must exhibit at least 5 out of 9 specific criteria. Let's understand these as human experiences, not just clinical checkboxes. Frantic efforts to avoid real or imagined abandonment. Imagine your nervous system has been trained that the people you love will leave. The fear isn't a quiet worry. It's a fire alarm at the slightest hint of distance. A friend doesn't text back immediately, and your mind fills with certainty. They hate you. They're done. You've driven them away. The fear is so overwhelming that you might do anything to prevent it. Calling repeatedly, showing up unannounced, making threats or pleas. And ironically, these very actions can push people away, creating the abandonment you feared. Unstable and intense relationships, alternating between idealization and devaluation. When someone is good to you, they're perfect, your salvation, everything you need. But then they disappoint you. Maybe they cancel plans. Maybe they don't respond with enough enthusiasm. And suddenly, they're terrible, untrustworthy, deliberately cruel. The middle ground feels impossible to hold. Your emotions are so intense, they color everything, creating a black and white world where people are either completely safe or completely dangerous. Identity disturbance. Who are you? For someone with BPD, the answer shifts like sand. Your values, goals, your very personality seem to change, depending on who you're with or what situation you're in. You might adopt others' interests automatically, mirroring their speech patterns, desperately seeking a coherent sense of self. You look in the mirror and don't recognize yourself. Not in a psychotic way, but in the sense that there's a fundamental disconnect between your reflection and any stable internal identity. Impulsivity in at least 2 potentially self-damaging areas. Reckless spending that maxes out credit cards. Substance use that escalates without intention. Binge eating. Unsafe sex. Reckless driving. But here's what's often missed. These aren't frivolous choices or moral failures. They're desperate attempts to regulate unbearable emotional pain. When you're drowning in distress without effective coping skills, you reach for whatever makes the pain stop, even temporarily. Recurrent suicidal behavior, gestures, or threats, or self-mutilating behavior. This is perhaps the most misunderstood criterion. Studies show 70 to 75% of people with BPD will attempt suicide at least once in their lives. The completed suicide rate is around 6%. Devastatingly high. Self-harm, cutting, burning, hitting, transforms unbearable emotional pain into physical pain that feels more concrete, more manageable, more real. It's not attention-seeking in the manipulative sense people often assume. It's survival. Affective instability. Your emotional thermostat is broken. A minor criticism sends you spiraling into despair. A small kindness fills you with euphoria. These moods can shift within hours, sometimes minutes. You wake up feeling okay. Then a single interaction plunges you into darkness. Then something else lifts you briefly before you crash again. The intensity is exhausting, both for the person experiencing it and those around them. Chronic feelings of emptiness. Not sadness, not depression, exactly. Emptiness. A void inside that nothing seems to fill. Like being hollowed out with something essential missing. You can be surrounded by people and still feel this crushing absence of something. Purpose. meaning, self. It's one of the most difficult symptoms to describe and one of the most painful to endure. Inappropriate, intense anger or difficulty controlling anger. Rage that feels disproportionate to the trigger. You might explode over something minor, a perceived slight, a change in plans, with an intensity that surprises even you. The anger erupts without warning and leaves shame in its wake. Often, this rage is rooted in years of invalidation, of having your emotional experience dismissed or minimized. Transient stress-related paranoid ideation or severe dissociative symptoms. Under stress, you might experience temporary breaks from reality, feeling like you're watching yourself from outside your body, feeling like the world isn't real, like you're moving through a dream. Brief paranoid thoughts that others are conspiring against you or deliberately trying to hurt you. These episodes are temporary but terrifying, adding another layer of distress to an already overwhelming experience. These 9 criteria describe patterns of suffering, and here's something crucial. You only need 5 out of 9 for diagnosis. This means 2 people with BPD might have very different presentations. One might struggle primarily with emptiness, anger, and impulsivity. Another might struggle with abandonment fears, relationship instability, and dissociation. The heterogeneity of BPD makes it complex to understand and treat. BPD affects between 1.6 and 5.9% of the general population. That's roughly 14 million Americans. It's more commonly diagnosed in women, with some studies suggesting about a 3-to-1 ratio. Though whether this reflects true prevalence or diagnostic bias remains an open question. And about 85% of people with BPD also meet criteria for at least one other mental health condition. Mood disorders, anxiety disorders, PTSD, substance use, disorders, eating disorders. This comorbidity complicates both diagnosis and treatment. The neuroscience of BPD. Imagine your brain is a city. There's the financial district, your prefrontal cortex, where executive decisions are made, where you plan for the future, regulate impulses, and think rationally about situations. And there's the old quarter, the limbic system, including structures like the amygdala and hippocampus, where emotions live, where fear responses originate, where memories are processed. In a well-functioning brain city, these districts communicate smoothly. The emotional old quarter sends up signals about what's happening, and the rational financial district processes those signals, puts them in context, decides how to respond. But in BPD, something has disrupted this communication system. The amygdala is your emotional alarm system. When it detects potential threat, it triggers the fight or flight response. In people with BPD, neuroimaging studies consistently show heightened amygdala activity, especially in response to negative emotional stimuli like angry faces or rejection scenarios. The alarm system is set to maximum sensitivity, firing off warnings at stimuli that others might barely notice. But here's where it gets more complex. Some studies have also found reduced volume in the amygdala in people with BPD, between 8 and 24% smaller than average. How do we reconcile hyperactivity with reduced size? Researchers have proposed that chronic stress, particularly in childhood, may cause the amygdala to be initially overactive, and the evidence suggests that this sustained overactivation could eventually lead to structural changes, a kind of wear and tear on the system. The hippocampus, crucial for memory consolidation and stress regulation, consistently shows volume reductions of 10 to 20% in people with BPD, particularly in those with trauma histories. This isn't surprising when you understand the mechanism. Prolonged exposure to stress hormones like cortisol can actually damage hippocampal neurons. When a child grows up in chronic stress, their developing hippocampus is bathed in cortisol, potentially impairing its normal growth. The prefrontal cortex, your brain's executive control center, shows reduced activity in BPD, particularly during emotional processing tasks. It's as if the brakes on the emotional system are weakened. The amygdala sends up urgent signals of panic or rage, and the prefrontal cortex, which should be able to step in with rational perspective and regulation, is under-equipped to respond effectively. Crucially, functional neuroimaging reveals reduced connectivity between the amygdala and prefrontal cortex. These two regions aren't talking to each other effectively. When intense emotions arise, they flood the system unchecked, because the communication pathways that should allow top-down regulation are disrupted. There's also evidence of altered connectivity in what's called the default mode network, a set of brain regions that activate when you're at rest, when your mind wanders, when you're thinking about yourself and your place in the world. In BPD, this network shows unusual patterns of activity. Given that the default mode network plays a crucial role in self-referential thinking and maintaining a coherent sense of identity, researchers have proposed a compelling link. These connectivity differences could help explain the identity disturbance people with BPD experience. While we can't yet prove direct causation, the correlation is strong enough to suggest this neural pattern may be one biological mechanism underlying the phenomenological experience of identity instability. Now, are these brain differences the cause or the result of BPD? Research suggests both in a complex interplay. There appear to be biological vulnerabilities, genetic factors, temperamental traits that create susceptibility to developing BPD. But environmental factors, particularly trauma and invalidation, shape how the brain develops during critical periods. And the disorder itself, the chronic stress of living with intense emotional dysregulation, may further alter brain structure over time. And here's something hopeful. The brain has neuroplasticity. It can change. Longitudinal neuroimaging studies of people who've undergone effective treatment for BPD demonstrate measurable changes in brain function. The prefrontal cortex shows increased activation. Emotional reactivity decreases. The data strongly suggests that therapeutic interventions don't just change behavior and subjective experience. They appear to alter the underlying neural architecture. The brain, given the right support and consistent practice of new skills, can reorganize itself. Trauma and BPD, the deep connection. If you ask someone with BPD about their childhood, more often than not, you'll hear a story marked by pain. Studies consistently show that between 30 and 90% of individuals with BPD experience childhood abuse or neglect. In Judith Herman's landmark 1989 study, 81% of people with BPD reported major childhood trauma. The breakdown: 71% experienced physical abuse, 68% experienced sexual abuse, and 62% witnessed domestic violence. These aren't abstract statistics. They're childhoods marked by betrayal, fear, and suffering. BPD shows a stronger link to childhood trauma than any other psychiatric condition. The most common forms are emotional abuse, reported in 42.5% of cases, and physical neglect in nearly 49%. Emotional abuse: being told you're worthless, stupid, unwanted, and emotional neglect. Having your feelings consistently ignored or dismissed can be just as damaging as physical harm, though they leave no visible scars. But trauma doesn't cause BPD in a simple, direct way. Plenty of people experience significant childhood trauma and don't develop BPD. And some people with BPD don't report significant trauma. So what's happening? The current understanding involves what's called a diathesis stress model. Some people are born with certain temperamental traits that make them more emotionally reactive. A lower threshold for emotional arousal, difficulty returning to baseline after emotional activation, genetic variations affecting neurotransmitter systems like serotonin or stress hormone regulation. This is the diathesis, the vulnerability. Then comes stress, adverse childhood experiences, trauma, chronic invalidation. When you combine biological vulnerability with environmental stress, you create conditions favorable for the development of the disorder. Marcia Linehan, the psychologist who would go on to develop dialectical behavior therapy, proposed what she called a biosocial theory. She suggested that BPD arises from a transaction between biological emotional vulnerability and an invalidating environment. The child is born with a tendency toward intense emotions, difficulty regulating those emotions, and quick return to baseline after emotional arousal. Then, that child grows up in an environment that invalidates their emotional experiences, tells them their feelings are wrong, overreactions, manipulative, bad. The invalidation teaches the child to distrust their own emotional experiences, but it doesn't give them the tools to regulate those emotions effectively. So they develop maladaptive strategies, extreme behaviors, desperate attempts to get their needs met, or to escape unbearable internal states. These strategies might work in the short term, but cause long-term problems. Invalidation. The word sounds clinical, but it's deeply personal. It's the child who says, "I'm scared," and the parent responds, "Don't be ridiculous. There's nothing to be scared of." The child who's crying and is told, "Stop being so dramatic, you're fine." The adolescent who expresses hurt and is met with, "You're too sensitive, you overreact to everything." Genuine pain, met with dismissal. Authentic emotional experiences, treated as if they're wrong or bad. Over time, the child learns that their internal experience can't be trusted, that their emotions are problems to be suppressed, rather than valid responses to be understood. Childhood trauma has specific, measurable effects on the developing brain. Remember those hippocampal and amygdala reductions we talked about? They're particularly pronounced in individuals with trauma histories. Childhood trauma activates the hypothalamic pituitary adrenal axis, the stress response system. Chronic activation during critical developmental periods causes lasting changes in how this system functions. High cortisol levels can be toxic to the developing hippocampus, interfering with normal neural growth. The amygdala becomes hyperreactive, its threat detection system calibrated to a dangerous world where vigilance is necessary for survival. The prefrontal cortex doesn't develop robust regulatory pathways because it's constantly overwhelmed by the emotional signals from below. The result? An adult who experiences emotions with extraordinary intensity, who perceives rejection and abandonment in ambiguous situations, who struggles to self-soothe or regulate distress, who has difficulty trusting others or maintaining a stable sense of self. These aren't character flaws. They're the predictable outcomes of a nervous system shaped by adversity. The lived experience. We've talked about criteria and brain structures and statistics, but let's step back from the clinical perspective. What's it actually like to live with BPD from the inside? Imagine waking up in the morning and before you're even fully conscious, there's a tightness in your chest, an unnamed dread. You check your phone immediately, looking for messages, reassurance that the people in your life haven't disappeared overnight. If there are messages, you feel a moment of relief, but you analyze them. Were they warm enough? Enthusiastic enough? Or are they pulling away? If there aren't messages, or if they're brief, the dread intensifies into something heavier. Why didn't they write more? Are they angry? Have you done something wrong? Did you say too much last night? You look in the mirror as you get ready, and you're not sure who you're seeing. Not in a psychotic way. You know it's you. But there's a disconnect. Is this who you are? Yesterday you felt certain about your career goals, your values, what you wanted from life. Today, everything feels contingent, questionable. Maybe you should change your appearance. Maybe if you were different, thinner, funnier, quieter, louder, you'd be lovable. You go to work or school and you're performing, not consciously lying, but automatically adjusting yourself to match what you think others want from you. With one colleague, you're outgoing and funny, cracking jokes, being the life of the conversation. With another, you're quiet and thoughtful, nodding seriously, mirroring their demeanor. With your boss, you become whoever you think they want you to be. It's exhausting, this constant shifting, this chameleon existence. And underneath it all, there's a question that haunts you. Which one is the real you? Or are you just a series of masks with nothing underneath? Someone makes a comment at work, maybe slightly critical. This report could use more detail, maybe just neutral. You seem quiet today, but in your mind, in your body, it becomes evidence of your fundamental unworthiness. They hate you. They've always hated you. You've been fooling yourself thinking they respected you. The emotion is overwhelming, immediate, physical. Your heart races. Your chest tightens. You want to lash out, to defend yourself, or to withdraw completely, to hide. Your rational mind, some distant part of you, knows you're overreacting, but your emotional mind is screaming, and the emotional mind is sick. So much louder, so much more convincing. And here's what makes it even harder. You're aware of your own intensity. You can see yourself spiraling, like watching a car crash in slow motion. You know, intellectually, that your reaction is disproportionate to the trigger. But knowing doesn't help. Knowing doesn't make it stop. It's like watching yourself from behind glass. You can see what's happening, but you can't reach through to change it. And this awareness adds yet another layer, shame. Not just the initial hurt, but shame about how you're reacting to the hurt. Shame about being too much, too intense, too broken. You make it through the day. Later, you're alone in your apartment, and the emptiness settles in. Not sadness. You almost wish it were sadness, because sadness is something. Sadness has texture, has meaning. This is nothing. A void, an absence, like being hollowed out with something essential missing. You scroll through your phone, looking for something, anything, to fill it. Old conversations. Social media. You think about calling someone, reaching out, but what would you say? I feel empty. How do you explain that you're drowning in a feeling of non-existence? So you don't call. Maybe you eat, even though you're not hungry, just to feel something. Maybe you shop online, adding things to your cart that you can't afford. Maybe you have a drink, or two, or more. The behavior provides momentary relief, a brief distraction. The relief doesn't last. It never lasts. The fear of abandonment isn't an abstract concept. It's visceral, constant, exhausting. Every relationship feels precarious, like walking on ice that could crack at any moment. You analyze every interaction, searching for signs. Did they take a little longer to respond to your text? Did they seem less interested when you were talking? Are they spending more time with someone else? The hypervigilance is relentless, and sometimes the fear becomes so unbearable, so consuming, that you preemptively push people away. You pick a fight. You withdraw. You create distance before they can. Better to leave than be left. Better to control the inevitable abandonment than wait passively for it to happen. This creates impossible contradictions. You desperately need connection, crave it, can't survive without it, but you're terrified of getting close, of being vulnerable, of depending on someone who will inevitably leave. You idealize someone when they're kind to you. They're perfect, your salvation, everything you need. But then they disappoint you, even in small ways. They cancel plans. They don't respond with enough enthusiasm. They criticize you gently. and suddenly they plummet in your estimation. They're terrible, untrustworthy, deliberately cruel. The middle ground feels impossible to hold. Your emotions are so intense, they color everything, creating a black and white world where people are either completely safe or completely dangerous. The anger, when it comes, crashes over you like a wave. In that moment, you're certain it's justified. They hurt you. They deserve your rage. You might lash out with words that cut deep, designed to wound. You might throw something, slam a door, storm out. But then the wave recedes as quickly as it came, and you're left standing in the wreckage, and the shame floods in. Why do you react this way? Why can't you just be normal? Why can't you control yourself like other people seem to? For someone with BPD, emotions aren't waves that rise, crest, and gently fall. They're tsunamis, one after another, relentlessly crashing down. You're always drowning or bracing for the next wave. There's no calm sea, no peaceful harbor. But here's what we don't talk about enough. People with BPD also have extraordinary capacities. Their emotional sensitivity, which can be so painful, also means they're often deeply empathetic. They can sense what others are feeling with uncanny accuracy, picking up on subtle shifts in tone, expression, energy. Many are creative, passionate, capable of profound connection when they feel safe. They care deeply about causes, about people, about making meaning from their suffering. The same intensity that causes so much pain can fuel art, advocacy, deep caring for others. The disorder doesn't define the totality of who they are. The weight of stigma. The stigma surrounding BPD is pervasive and harmful, and it comes from within the mental health system itself. Attention-seeking, manipulative, difficult, untreatable. These words follow people with BPD. They're whispered in emergency rooms, used to justify refusing treatment, written in clinical notes with implied judgment. The attention-seeking label is particularly cruel. When someone with BPD engages in self-harm or makes suicidal gestures, it's often dismissed as mere attention-seeking, as if seeking attention when you're in unbearable distress is somehow illegitimate. These behaviors are communications of suffering. They're saying, "I am in pain. I need help. Please see me." To dismiss this as attention-seeking in a pejorative sense is to miss the point entirely. The manipulative stereotype is equally problematic. When someone with BPD threatens self-harm to prevent a partner from leaving, they're not coolly calculating strategic manipulation. They're panicking. Their nervous system is screaming danger. The behavior might have the effect of manipulation, but that's different from manipulative intent. Studies show that when clinicians are presented with identical case vignettes, but one is labeled with BPD and the other with depression, they respond more negatively to the BPD case. Less empathy, less optimism about treatment outcomes, more frustration. The mere presence of the diagnosis changes how the person is perceived. In one survey, 57% of psychiatrists admitted they had chosen not to disclose a BPD diagnosis to a patient because they feared the stigma. 37% chose not to document it in medical records. Think about that. Clinicians are so aware of how stigmatizing the diagnosis is that they actively hide it from patients and colleagues. The stigma extends to emergency rooms. People with BPD presenting with legitimate physical concerns are sometimes dismissed as exaggerating or drug-seeking. Their pain is discounted. As soon as staff see BPD in the chart, assumptions are made. There's also gender bias woven into this. BPD is diagnosed more frequently in women, with studies suggesting about a 3-to-1 ratio. Whether this reflects true prevalence or diagnostic bias remains an open question. Some of the stereotypes applied to BPD, emotional, dramatic, manipulative, bear striking resemblance to broader sexist tropes about women in general. Based on clinical observations and research data, when women express intense emotions, they appear more likely to receive pathologizing diagnoses, while men with similar symptoms may be diagnosed differently or channeled into different systems entirely. Researchers have proposed that men with BPD traits may be more likely to end up in the criminal justice system, receiving diagnoses like antisocial personality disorder, while women with similar presentations enter the mental health system with a BPD label. The available evidence supports this interpretation, suggesting systemic biases in how emotional dysregulation is understood and treated based on gender. But here's what's changing, slowly. Awareness. Advocacy. People with BPD are speaking up, telling their stories, challenging the stereotypes. Researchers are producing evidence that contradicts the old myths. Clinicians are learning that these patients aren't untreatable monsters. They're traumatized individuals in desperate need of compassion and evidence-based care. Treatment, the path to recovery. Remember when I said BPD was once considered untreatable? Here's the truth from decades of research. BPD is not only treatable, it has one of the best prognoses of any major mental health condition. The McLean study of adult development followed over 300 individuals with BPD for more than 2 decades. The findings were remarkable. 100% achieved remission at some point. 100%. And 77% achieved remission, lasting 12 years or more. Other longitudinal studies found similar results. Remission rates at 10 years range from 85 to 93%. Now, there's a distinction between remission and recovery. Remission means no longer meeting diagnostic criteria. The symptoms have subsided enough that you don't qualify for the diagnosis anymore. Recovery means not only symptomatic remission, but also good social and vocational functioning, having meaningful relationships, working or engaging in purposeful activity, experiencing quality of life. Recovery rates are around 50 to 60%, still remarkable for a condition once seen as lifelong and unchangeable. Remission isn't always permanent. About 30 to 40% of people experience recurrence at some point. But with each sustained period of remission, the likelihood of lasting recovery increases. And here's the key. The pathway to recovery is appropriate, evidence-based psychotherapy. So what treatments work? The gold standard, with the most research support, is dialectical behavior therapy. DBT, developed in the late 1980s by psychologist Marcia Linehan. And here's something you need to know about Linehan. Something that changes everything about this story. For years, she was the expert, the researcher, the clinician who wrote the treatment manuals, who trained therapists worldwide, who testified before Congress about BPD treatment. Professional, academic, detached in the way scientists are supposed to be. And then, in 2011, at a public lecture, she revealed something that stunned the mental health community. She herself had been hospitalized for BPD as a young woman. She had been one of those patients that the system had given up on. She had been told she was hopeless, treatment resistant, one of the difficult ones. She had been locked in seclusion. She had burned herself with cigarettes. She had been so desperate to escape her suffering that she'd repeatedly banged her head against the walls of her hospital room. The woman who would go on to develop the most effective treatment for BPD had BPD. Let that reverberate for a moment. The disorder that clinicians called untreatable was treated by someone who lived it, who understood from the inside what it meant to feel emotions so intensely they seemed to tear you apart, who knew what invalidation felt like, who had been abandoned by the very system she would later transform. This isn't just an interesting biographical detail. This is the heart of why DBT works in ways that earlier treatments didn't. Because Linehan's personal experience with the disorder fundamentally informed her approach, though her work is grounded in rigorous science, not just personal insight. She understood, in a way that purely academic researchers couldn't, what these patients needed, Not lectures about cognitive distortions, not behavioral modification rooted in the assumption that they were fundamentally broken, but validation, acceptance. The message, your pain makes sense, and from this place of understanding, we can build skills together. DBT is based on cognitive behavioral principles, but with a critical addition, acceptance. Early versions of cognitive behavioral therapy for BPD focus solely on changing thoughts and behaviors, on fixing what was wrong. But patients found this invalidating. They felt blamed, criticized, misunderstood. Linehan realized that before you can ask someone to change, you need to accept them as they are. You need to validate their suffering, communicate that their responses make sense given their history and biology. Only then, from a place of acceptance, can you work on change. This is the dialectical part, the synthesis of opposites, the both and rather than either or. The therapist says, in effect, I see your pain. I understand why you're struggling. Your responses make sense, and I believe you can learn new skills to manage that struggle more effectively. Both things are true simultaneously. DBT has 4 main components. Individual therapy, usually once a week, where the therapist and client work through crises, address behaviors that interfere with life, and practice applying skills. Group skills training, also weekly, where clients learn specific skills in 4 modules. Phone coaching, where clients can call their therapist between sessions when they're in crisis. And a therapist consultation team, where therapists meet regularly to support each other and stay true to the model. The 4 skill modules are crucial. Mindfulness teaches present moment awareness without judgment. Instead of, they didn't text back, they hate me, they're going to leave, I'll be alone forever. You learn to notice, I'm having the thought that they hate me. I'm feeling anxiety in my chest. This feeling will pass. You're creating distance between yourself and your thoughts, recognizing that thoughts aren't facts and feelings aren't permanent. Distress tolerance teaches how to survive crises without making things worse. Tip skills. Temperature. Splashing cold water on your face or holding ice activates your dive reflex, physiologically slowing your heart rate. Intense exercise, burning off the flood of adrenaline. Paced breathing, engaging your parasympathetic nervous system. These aren't just feel-good suggestions. They're grounded in physiology. Radical acceptance is another distress tolerance skill. Accepting reality as it is, even when it's painful, even when it's not what you want. Not approving of it or resigning yourself to it forever, but acknowledging what is true right now without fighting it, so you can figure out how to move forward. Emotion regulation teaches how to identify emotions, understand their functions, reduce vulnerability to negative emotions, and increase positive experiences. It starts with naming what you're feeling. When you can name it, you can work with it. Please. Skills help reduce emotional vulnerability. Take care of physical health. Treat eye illness. Eat balanced meals. Avoid altering drugs. Sleep well. Exercise. When your basic physical needs are met, your emotional system is more stable. Interpersonal effectiveness teaches how to ask for what you need, say no when necessary, and maintain self-respect in relationships. Dear man, describe the situation objectively. Express your feelings. Assert what you want. Reinforce why it matters. Stay mindful of your goal. Appear confident. Negotiate if needed. These are practical scripts for navigating difficult conversations. Randomized controlled trials have repeatedly demonstrated DBT's effectiveness. It reduces suicidal behavior, self-harm, substance use, and psychiatric hospitalizations. It improves overall functioning and quality of life. Other effective treatments exist. Mentalization-based treatment focuses on improving the ability to understand your own and others' mental states. Schema therapy addresses maladaptive core beliefs formed in childhood. Transference-focused psychotherapy works with relationship patterns in the therapeutic relationship. Good psychiatric management offers accessible support for general psychiatric providers. What about medication? There's no medication that treats BPD itself, but medications can help with comorbid conditions. Antidepressants for depression, mood stabilizers for emotional volatility, anxiolytics for severe anxiety. The core work, though, happens in therapy. What does recovery actually look like? It looks like waking up one morning and realizing you didn't immediately check your phone. The anxious monitoring has loosened its grip. It looks like having a disagreement and being able to step back. Breathe. Use your distress tolerance skills instead of spiraling. The space between stimulus and response gradually widening. Recovery looks like starting to trust your own perceptions. Like saying, I'm feeling abandoned right now, but I recognize this feeling might not match reality. The identity disturbance softening. You start to develop a through line, a sense of continuity. It looks like relationships that last. Not perfect relationships, but relationships where you can repair after ruptures, where you can apologize without collapsing into shame. The emptiness filling with things that matter. The emotional waves becoming smaller, more manageable. And perhaps most importantly, recovery looks like self-compassion. That harsh inner voice that said you were worthless, unfixable, too much. It softens. You start to speak to yourself the way you'd speak to a friend, with kindness, with understanding. Mary Zanarini, who led the McLean study, put it this way: BPD is the most treatable major mental health condition. The treatment is psychotherapy, not medications. That statement shifts the entire narrative from hopelessness to hope. Relationships. The crucible of healing BPD doesn't exist in a vacuum. It plays out in relationships, with family, friends, romantic partners. And those relationships are often the site of both the greatest suffering and the greatest healing. For many people with BPD, family relationships are complicated, layered with history. If the disorder arose from childhood trauma or invalidation, the family may have been the source of that harm. Parents may struggle with guilt, confusion, denial. Siblings may feel neglected because so much family energy went toward managing crises. There may be years of hurt, resentment, patterns that feel impossible to break. But family can also be a crucial source of support. When family members educate themselves about BPD, learn to communicate effectively without invalidating, set healthy boundaries while remaining compassionate, relationships can heal. Family therapy, particularly approaches like family connections designed specifically for BPD, can make a significant difference. The challenge for family members is walking the line between support and enabling. You want to help, but you don't want to reinforce unhealthy patterns. You want to be there during crises, but you also need to take care of yourself. Burnout is real. Compassion fatigue is real. Setting boundaries doesn't mean abandoning your loved one. It means recognizing that you can't fix their disorder, but you can offer consistent, loving support while they do the work of recovery. Romantic relationships can be particularly intense when one partner has BPD. The fear of abandonment, the tendency to idealize, then devalue, the emotional volatility. These create a roller coaster dynamic. The person with BPD might cling desperately, needing constant reassurance, then push away in self-protection. They might test the relationship constantly, unconsciously searching for proof that the other person really cares, or looking for evidence that they're about to be abandoned. For the partner without BPD, this can be exhausting and confusing. One day you're the most wonderful person in the world. The next day you're terrible, and you can't figure out what you did wrong. You walk on eggshells, trying not to trigger an outburst. You might sacrifice your own needs to keep the peace. And this isn't healthy for either person. But relationships involving BPD can work, especially when the person with BPD is in treatment and actively working on skills. Communication becomes key. The person with BPD needs to practice identifying and expressing their needs directly, rather than expecting their partner to read their mind or respond to crisis behaviors. They need to work on tolerating distress when the partner can't immediately soothe them, on recognizing when their perceptions might be skewed by emotional intensity. The partner without BPD needs to learn about the disorder, understand that the behaviors aren't personal attacks, set and maintain boundaries, and take care of their own emotional well-being. Couples therapy can provide a structured space for this work. Cultural considerations. Most BPD research has been conducted in Western, educated, industrialized, rich, democratic societies. What researchers call weird populations. The diagnostic criteria themselves reflect Western individualistic values and norms. The emphasis on maintaining a stable sense of self, for instance, presumes that a coherent individual identity is important and possible. But in more collectivist cultures, identity might be more fluid, more dependent on social roles and relationships. This raises a critical question. Does that mean people in those cultures are more likely to have BPD? Or, as cross-cultural researchers increasingly suggest, does it mean the diagnostic criteria themselves are culturally biased? The evidence leans toward the latter interpretation. When we pathologize what may be culturally normative patterns of self-experience, we risk imposing Western psychiatric models onto fundamentally different ways of being in the world. Access to treatment is another critical issue. DBT and other evidence-based therapies require trained clinicians, which are scarce in many areas. Rural communities, low-income populations, people without insurance, they face significant barriers. The research tells us recovery is possible, but only if people can access the treatments that work. Moving forward, compassion and change. Changing the broader narrative around BPD requires work on multiple fronts. First, education. Mental health professionals need comprehensive training that challenges stereotypes and emphasizes treatability. Medical schools and psychology. Programs need to teach about BPD with compassion and evidence, not outdated assumptions. Second, advocacy. People with BPD sharing their stories, their struggles, and their recoveries. The more faces and voices associated with BPD, the harder it becomes to maintain dehumanizing stereotypes. Third, research. Continued investigation into causes, mechanisms of change, factors promoting recovery. Fourth, policy. Insurance companies need to adequately cover BPD treatment, which can be intensive. Mental health parity laws need enforcement. Fifth, and perhaps most importantly, compassion. Every person with BPD is an individual with their own story, strengths, struggles. They're not a diagnosis. They're human beings who deserve kindness, not judgment. Language matters. A person with BPD, not a borderline. Describing observations without attributing negative motives. Validation matters. When someone is in distress, they need to hear their pain is real. This doesn't mean agreeing with distorted perceptions or enabling harmful behaviors. It means, I see you. I believe you're suffering. Let's figure out how to help. Boundaries matter. Compassion doesn't mean accepting abuse. You can care about someone with BPD and still protect yourself. Have limits. Hope matters. The message must shift from "this is who you are" to "you're struggling right now, and with help, you can feel better." Closing, the wholeness we seek. We've been on a long journey tonight, from the history of a misunderstood diagnosis, through neuroscience and trauma, into the heart of what it means to live with and recover from BPD. And now we come back to where we started. The lie, remember? The lie that said BPD was untreatable. The lie that destroyed lives. That kept people from getting help. That made clinicians turn away. Here's what that lie cost. Decades of unnecessary suffering. Thousands who could have been helped, weren't. Relationships that could have been repaired, weren't. Lives that could have been lived fully, weren't. But here's what's true. BPD is not a life sentence. It's a description of suffering that has causes, that makes sense in context, and that can be alleviated. The research is unambiguous. The treatment outcomes are remarkable. The lie is dead, but we're still living with its legacy, and that's what needs to change. The person who wakes up feeling empty, who struggles to know who they are, who fears abandonment so intensely it shapes every interaction, that person is not broken. They're responding to a nervous system shaped by pain, by invalidation, by a mismatch between their emotional intensity and the world's capacity to hold it. But with the right support, they can develop new strategies. Better ones. Healthier ones. Marsha Linehan said people with BPD are like people with third-degree burns over 90% of their bodies. In constant, excruciating pain. The slightest touch hurts. And then we tell them, "You're overreacting. You're too sensitive." We invalidate the reality of their experience. But what if we said, "I see that you're in pain. I can't take away the burns, but I can help you learn to care for them, to gradually heal"? What if we approached BPD with the same compassion we'd offer someone with any other painful condition? The research tells us this works. Recovery happens. Not always quickly, not always linearly, but over time, with persistence and support, lives improve. Emotions become manageable. Relationships stabilize. The emptiness fills with meaning and connection and self-understanding. And here's something beautiful. The sensitivity that caused so much pain can become a strength. The ability to feel deeply, to empathize intensely, to care passionately. These are gifts. Many who recover from BPD go on to help others. They become therapists, advocates, artists. So if you're listening and you have BPD, or you think you might, or you love someone who does, know this. You are not alone. You are not hopeless. You are not unlovable or unfixable or too much. You are a human being experiencing profound suffering, and that suffering can be eased. Help is available. Recovery is possible. You deserve compassion, including from yourself. Recovery doesn't mean becoming a different person. It means learning to live with your intensity in a way that works for you. Building a life where you can feel deeply without being destroyed. Relationships where you can be authentic. And for those who love someone with BPD, your person is in there. Underneath the chaos, there's someone who wants connection as much as you do. Your boundaries matter. Your well-being matters. But so does your hope. When you believe in their capacity to change, it makes a difference. BPD asks us to understand that personality isn't fixed, that change is possible, that healing happens when we combine acceptance with commitment. It asks us to see past the diagnosis to the person, to offer hope grounded in evidence. The name borderline was always a misnomer. These individuals aren't on the border of anything. They're right here, fully present, fully human, so fully deserving of care. And when we meet them with the tools and compassion they need, transformation becomes not just possible, but likely. Perfection was never the goal. Wholeness is. And wholeness includes every part of the human experience. The joy and the pain, the connection and the solitude, the intensity and the calm. People with BPD aren't seeking to eliminate their emotions. They're seeking to live with them, to understand them, to not be controlled by them. That's the journey. And it's one we can all support, whether as professionals, loved ones, or fellow humans trying to understand what it means to feel, to struggle, to survive, and ultimately, to thrive. Thank you for listening tonight. If this resonated with you, please consider subscribing to this channel. And as always, take care of yourself. You're doing better than you think.